Hello, everyone. Hello, Benita.
Hi, Vernon.
Hello,
Hi,
Jacques.
Vernon. Hi, Jacques.
Good to see you all here. Benita, I'm just going to send you a message in the chat quickly. Okay.
Okay.
And we can probably start in a minute, or let me see what the time is now. Yeah, maybe we'll give it another minute and then we'll get going.
Hi, can you hear me? I'm just testing my audio.
Yes, can hear you, Romana.
Thank you, Dr. Philip.
Romana, are you going first or is Jeremy going first?
Jeremy is going first.
Okay, great. I think we can get going. Welcome, everybody. It's wonderful to have you here again on a Monday afternoon. And I have great expectations that this afternoon session will be no less exciting or interesting than the ones we've been getting used to. We're very excited to get some new speakers with a topic that, as far as I remember, we haven't covered before, but a very, very important one at that. And this afternoon's session that will be chaired by Dr. Benita Philip from Chris Hani Baragwanath, the head of division there, is on HHV-8 and the associated lymphoproliferative disorders. And I think what is exciting about this afternoon session is that it is a collaborative effort, a multidisciplinary session, including someone from hematology as well as someone from infectious diseases. Thank you, Gerdien, for the next slide. So just as a reminder, the weekly sessions are recorded. You can find them on the bloodsa.org.za website. If you want to quickly take a sneak peek now, really, really wonderful website. Not only hosting all the recordings, but a lot of things currently happening in hematology, which you haven't noticed is a very exciting space. You will be able to follow there and see what's going on. Then please take part. You know, the session, these type of sessions is like when you get together for in Afrikaans we say a bring en braai. You come together, everybody brings something to the table. So please bring something to the table. Come and put your questions or comments in the chat box, and make this meeting your own. For those who are registered in South Africa, your CPD points will automatically be submitted to the HPCSA, so you don't have to worry about that. If you are registered in another country and you want proof of attendance, you can email Melanie at the email address that you can see on the screen. Now, to get that one CPD point, you do have to attend 60 minutes. The system automatically looks at that. Next slide. So these are the faces of the people who do the very hard work behind the screen. Prof. Stelverburg, who's actually on leave this month. Gerdien, Dr. Gerdien Kritzinger, who is the National Training Coordinator for Blood SA and does most of the organizing of these weekly sessions. And Melanie Davids, our UCT Secretary, who also administrates the CPD. Thank you. So these are our two speakers, and I think at this point I'm going to hand over to Dr. Venita Phillip, who will be chairing this afternoon session. I just want to say again, thank you, Venita. Venita is a fantastic colleague and partner in crime. We're doing all sorts of things together as heads of division around the country. And it's just been such a productive and great collaboration between all of us around the country. You know, Fatima and Charlene and Jacques and Venita and everybody that's working together to try and do our part in making hematology as interesting, exciting, and good as possible for the sake of our trainees and our patients. So with that, Venita, I'm going to hand over to you to introduce the speakers. Thank you.
Thank you very much, Vernon, for your kind words as well. And thanks for the introduction. First speaker today is going to be Dr. Jeremy Nell, who is a graduate from the University of Cape Town, but did his physician and infectious diseases from the University of Witwatersrand. He is president of the Infectious Diseases Society of South Africa and an active member of the Southern African HIV Clinicians Society. He has published research in the fields of HIV, TB, non-tuberculous mycobacteria, COVID, cryptococcal meningitis. And he has led or participated in multiple clinical trials. He was recently awarded a diploma in tropical medicine and hygiene from the Royal College of Physicians and completed a fellowship in transplant infectious diseases at the University of North Carolina. And Jeremy, thank you for all your assistance in the hematology unit. And I will ask you to please start the talk if you're ready.
Great. Thank you very much to Dr. Phillip as well, who taught me hematology when I was a medical officer going through. Not any good at it, I promise. I've gone to the much easier profession of infectious diseases, but I do remember the time fondly. So I'm going to talk a little bit about HHV-8 and skim over the heme parts of it to some degree, because that's going to be covered by Romani Yassat, who's going to be far more qualified to cover those aspects. But I thought I'd introduce the virus and just give you a sort of an overview, and then we'll get into the hematology parts with the next speaker more. I thought this was quite funny, and it's a nice way to start thinking about this disease, because it's always been a tricky disease. The gentleman who first described what would be called Kaposi sarcoma was born Moritz Kohn in a region in Hungary. The river that the town was it's just situated on as the Kapos River, and the town is the Kaposvar, which gives you a clue as to what happened. He became a very famous dermatologist in Vienna in the 1800s. He was probably the world's most famous dermatologist at the time. He worked through and he fused the sort of visual aspect of dermatology with a very keen pathological sense. He'd biopsy them and fuse those two parts together, which really took hematology to the next level. And he decided, though, when he got to Vienna, that it was very difficult being known as Kohn, because there were far too many physicians called Kohn. So he decided he was change his surname to Kaposi to avoid confusion with at least 5 other physicians. And he also just said he preferred Morris as opposed to Moritz. So he was born Moritz Kohn and decided he would call himself Maurice Kaposi. He described what was known horribly as idiopathic multiple pigmented sarcoma of the skin, which is what we now know as Kaposi sarcoma, and it was named by a colleague of his after him, and he accepted the name. But it does offer a good opportunity for snobbishness. The way it's not Kaposi sarcoma, but the emphasis is on the first syllable, so it's Kaposi sarcoma. So you can always now go and correct all your colleagues and friends and be as annoying as possible about that. But this is the poor gentleman who discovered this. The tumor at the time, though, was well known really as something that affected mostly Mediterranean men and some of the Ashkenazi Jews. Very uncommon tumor. It took until the 1800s for it to be described. And then what happened in the 80s is the rate just shot off. So it went about 50 times higher than average. And it became very apparent to people wondering why they were seeing so many Kaposi sarcoma that it was associated with HIV. And it's so obvious now, but of course in the 80s and early 90s, that wasn't as obvious. And people tried all sorts of epidemiological links. They thought maybe it was CMV that was causing it. Maybe it was other herpes viruses like HSV. People even thought of some environmental things like nitrite inhalers and things like that. Lots of possibilities as to what they thought could cause it. And then in about 92, and it was eventually published by 94, this husband and wife team, Patrick Moore and Yuan Chang, described and identified the virus that was causing this. So most people were convinced by then it was a virus. They weren't sure which one. And they were able to identify this virus. And just refer you to the last line of that abstract. These KS-associated herpes-like sequences appear to define a new human herpes virus. So HHV-8 was only described in 1994. Now, the usual way this works is that if you were not born then, as some on the call may not have been, then it's ancient history. And if you were born there, it feels just like yesterday. I was in high school at the time, so it gives you some idea. These are recent things. We have only recently identified viruses which we now think of commonplace. I think, hepatitis B virus, I think, was the late 80s, and hepatitis C virus, was only first properly established in the 90s. The virus itself is from the herpes virus family, so there are 8 or 9, depending how you count, herpes viruses that affect humans. There's about 130 of them which have been described in the animal kingdom. They pretty much affect everything. So birds, reptiles, mammals, fish, even mollusks can get herpes viruses, but they tend to be quite specific for the species. So the species that affect humans can't affect cats and vice versa. Usually there's some, that doesn't always apply, but in many cases that is the case. It's what's technically called a gamma herpes virus. Its closest relative of those herpes virus family is EBV. So the herpes virus, the 8 in humans are HSV-1, 2, EBV, CMV, varicella zoster, and then the cheat names of HHV-6, 7, and 8. So of those, this HHV-8 is closest related to Epstein-Barr virus. It looks quite similar to the other herpes viruses down the electron microscope, apparently. Very difficult to tell apart. And that's, in fact, one of the reasons why initially it was thought to be CMV and not HHV-8 that caused Kaposi sarcoma. All of the herpes viruses are double-stranded DNA viruses. That has some implications, but not hugely clinically relevant. Many viruses are RNA, of course, viruses, but this is a DNA one. It's transmitted, interestingly, probably by saliva and sex being the 2 most common ways. Mostly, this is in high endemic situations like sub-Saharan Africa. When kids are born, they're HHV-8 seronegative, so that it's not intrauterine transmission. But within a couple of years, if you go back and test the kids, many of them are now starting to become HHV-8 positive. In sub-Saharan Africa, the prevalence of HHV-8 is up to 50%, sometimes even higher in certain settings, but on average about 50%, and highest in the world. But most of these people are acquiring it in childhood, so long before sex, but also not intrauterine. Most of these herpes viruses get spread then by saliva, and that's probably what's happening. So, you wipe in your mouth, you're touching a kid, then next, or you're chewing food for the kid and passing it on, or something like that, or just talking and spitting and a little bit lands in the mouth. People have identified HHV-8 in high concentrations in the saliva. It seems a pretty likely route. That wouldn't explain the high prevalence in HIV positive people, though, and it's likely that it also gets spread by sex, and there's other epidemiological evidence for that too. You can get it from blood transfusion, but obviously that's pretty rare. You can get it from organ transplants, that's even rarer. So really the dominant ways are saliva and sex to transmit this. It affects a lot of cells in the human body. B cells are one of its big targets. Endothelial cells are another big target. And if you think of those first 2, those are the 2 big targets. That explains most of the pathology, because most of the pathology is driven by either B cells or endothelial cells in terms of the neoplasms and things like that come from it. It can also infect macrophages, can also infect epithelial cells and a few other things, uses things like integrins as co-receptors. All of the herpes viruses have this characteristic of latency, which means that it's really in the cell and able to either stay totally quiet or do 1 or 2 very minor things to keep things ticking over. In HHV-8's case, the latency, it does produce 1 or 2 proteins when it's latent, but it's not destroying the cell, and it's not making new virions, virus particles. So it's just kind of sitting there, and that's a factor of all the herpes viruses. And because the herpes viruses also choose long-lived cells, like B cells in this case, which can also obviously replicate, then you end up with this effectively being incurable. So when you get HHV-8, it's with you forever. Doesn't always cause problems, of course, but it's certainly ineradicable once you've acquired it, like all the herpes virus group. The seroprevalence does vary a lot. Like I said, in sub-Saharan Africa, it's maybe 50%. In the Mediterranean regions, maybe 5%. Most of the rest of the world, 1 to 2%, and the least is probably Southeast Asia. In Japan, I think it was as low as 0.5%. So it's actually unusual for the herpes viruses in that they're not very geographically spread. Well, this one's not very geographically spread. HHV, most of the rest of them are pretty widely spread. You know, you get HSV everywhere in the world. Same with EBV and CMV. I thought this was quite interesting. This was when people have done genetic studies to look and do sort of phylogenetics, they can link these viruses by family tree effectively. They found that the genetic bottleneck occurred around the Xinjiang area, which is in the sort of northwest of China. And that there in that region, unlike most of the rest of the world, the common ancestor there was only about 2,000 years ago. So in other words, that's really kind of when the bottleneck occurred. And that 2,000 years it correlates perfectly with where the Silk Road was. The Silk Road was this big trade route from Rome, which was the dominant power at the time. In the Mediterranean, we remember there's, to this day, quite a high prevalence of HHV-8. And it's probable that the travelers going up and down this road spread it to that part of China, at least. So you can probably trace at least that part. You can blame the Romans for that, as the authors of this happy paper did. A really key point about all the herpes viruses, but HHV-8 in particular, is that several of them, like EBV, for example, and HHV-8, are linked to oncogenesis. But the oncogenesis, of course, is not a primary aim of the virus. The virus is not trying to cause a cancer to you on the whole. That's no benefit to itself. It's trying to spread its own genes. So the key thing really to understand here is that, at least in the case of HHV-8, is that its own efforts to avoid your own body's immune system and or to hijack the machinery of the host to generate more virus particles really is the thing that ends up by a byproduct almost giving this predisposition to cause cancer. It produces a whole bunch of anti-apoptotic proteins, which for you hematologists sounds like it's gunning for cancer and trying to make cancers, but of course anti-apoptosis is also very useful if you're a virus in the viral in the cell and trying to avoid the immune system attacking it. It can do a whole bunch of things. For example, one of the proteins it produces when it's latent in the cell is this so-called LANA, this latent nuclear antigen that inhibits p53. It inhibits the retinoblastoma protein, which I'm sure you know about. Also, this virus generates its own viral IL-6, interleukin-6, different from the human interleukin-6. Does have similar effects, but at a much lower potency. But one of the things this viral IL-6 does, it inhibits interferon alpha, which does a bunch of things, but one of them is, of course, interferon alpha prevents cell maturation and cell division, rather. So in other words, it's really preventing, again, cell division. Cyclin K, which is a protein it inhibits oncostatin M, which again has oncogenic properties. And so on and on. There's about 20 factors which have been covered. It can also, we know, transform human endothelial cells. So in this nice, elegant study in Nature, they literally took endothelial cells in vitro and injected them with HHV-8 and just allowed the HHV-8 to do what it does, and it transformed them into these different cells which had telomerase activity and also anchorage-independent growth. So again, it's all the kind of precursors of malignancies, but the key thing here, again, is it's not trying to cause them from the virus's perspective. It's really just trying to avoid the immune system. And if you happen to get a malignancy, so much the worse for you. But reminder that many, many, many people don't get HHV-8 malignancies unless they're immunocompromised in some other way. In other words, the normal, healthy people, this is that balance of causing cancers versus just replicating, doesn't tip over to cancer. Usually there's a host deficiency of some sort, which generates this. Not always, but in many cases. Primary infection must occur because people have to get HHV-8 somehow. It's not well described because people almost never recognize it. Almost all of them are going to go unrecognized. We don't know how many of them have symptoms versus how many of them are asymptomatic. There has been some very clever detective work which found what happens when you first get HHV-8, often in children, but can be in adults too. And you get a sort of upper respiratory tract illness, sometimes with a rash, fever, lymphadenopathy for a few days, sometimes diarrhea as well. This is what they get. They go to their doctors. The doctors say, I don't know what you've got. Maybe you've got 1, 2, 3, 4, or 5. Then no one ever thinks of HHV-8. And it goes away. It's self-limiting. So that's why we never find this, but it occurs. And when people have really studied it very hard, they have found these clinical syndromes. Kaposi sarcoma, of course, comes in these 4 kind of clinical variants. So moving on then eventually to what this virus is actually doing. The classic, and it's called classic because it was the first described type of Kaposi sarcoma, is not in any immunocompromised people. It's people who, usually elderly men in the Mediterranean region or Ashkenazi Jewish descent. There are some HL8 subtypes which are predisposed to Kaposi sarcoma, usually skin of the lower limbs. It's pretty indolent. It doesn't usually become a huge problem like we used to with the HIV positive patients. If you don't do anything about it, it does grumble on, but it tends not to kill you at all, and it may not even progress, and it usually stays on the low limbs. That's pretty much where it sits. The endemic form was the second to be described, and that's in sub-Saharan Africa mostly. And this probably just reflects, sadly, the prevalence, seroprevalence. In other words, it's been discovered where it's prevalent. It's not really different diseases. It's really just, they appear different because of where it's established and because of different host factors. 2 big forms. One of them is very much like the classic form. And then in kids, especially malnourished kids, it tends to be a bit more virulent, a lot more lymph node involvement, and a bit more aggressive course. Then we're more familiar with the epidemic ones, which is really the age-associated one. And that, I don't need to introduce, we've all seen many, many cases of because of a high HIV prevalence. That's the one which shot up in the 80s and really hasn't looked back since. Skin obviously very prominently involved, but obviously we're all familiar with it spreading to gastrointestinal tract, to the pulmonary tract and beyond. And then lastly, iatrogenic, so we can cause it if we immunocompromise a person. That's again the most rare of all the subtypes, but for example, transplant patients can develop Kaposi sarcoma even in the absence of, say, HIV or anything else if they happen to be HHV-8 positive when they start. If you get HHV-8 for the first time as a transplant patient, it actually ends up very aggressive because you've got no pre-existing immunity at all. So what happens then is you get a virulent course, and in fact you get like aggressive Kaposi sarcoma. You get HHV-8 this month, 2 months later you've got Kaposi sarcoma, and it's spreading to other organs the month after that. Very aggressive form, but again, very, very rare because you have to be at peak transplant immunosuppression and get HHV-8 at the same time. So pretty rare. The pictures you're all familiar with. Some of these are our patients, some of them are taken from the NIH. We notice it can look like a lot of things: papules, nodules, plaques. When it becomes worse and the immunosuppression gets worse, often becomes these fulminating, fungating masses. Often in the conjunctiva, interestingly, fairly commonplace for it to be. Can be in the nose, the oral mucosa as well. This is in the gastrointestinal tract. We're familiar with it there. That's in the gums there, but obviously can be in the hard palate, the soft palate. On the right is a patient in our hospital who got gastroscopy done, and that's what it looks like under gastroscopy. A little bit redder because the mucosa is thinner, so it looks more sort of cherry red rather than the purple that we're looking like. The purple color, incidentally, probably comes from a number of things. It's mostly because it's so vascular, and some of those vessels, those blood vessels, actually extravasate into the interstitium, and so it gives that sort of dusky brown color when skin's overlaid. If you took the skin off, it would be, don't do that, but if it would be slightly redder, like it looks down the mucosa over here. We're very familiar with this, obviously, as well in the lungs. It's one of the most feared complications because patients at this stage are very, very difficult to get better. It can look like a lot of things. It's classically called a flame-shaped hemorrhage, which is an annoying thing that you almost never see. But it can look like nodules, can look like alveolar infiltrates, interstitial infiltrates. Kind of one of the characteristic things you see on the right is sort of peribronchial thickening over here. I hope you can see my arrow, as well as some nodules there on the lung. But in the case of these cases, they usually occur secondary, well, when there's skin disease already. Not always, though. There's about 10% of the gastrointestinal and about 15% of the pulmonary can be without skin involvement. So in fact, the first thing you see is pulmonary or gastrointestinal. Very important to look in the mouth, because if you happen to see Kaposi sarcoma there, that's pretty indicative that what you're dealing with is visceral disease when you're worried about what this pulmonary infiltrate is. These patients get treated with PJP, they get treated for TB. It's a mess because it's very difficult to diagnose. Many of the pulmonologists are not keen to try and biopsy these lesions because they bleed a lot. And as you can imagine, they're very vascular tumors. Remember that they can iris. This was a very sad case we had many years ago, but you can see they had molluscum badly and Kaposi sarcoma. On the left of your screen is if you look at, for example, the ones on the nose, it was bad, and then the palate bad, really bad, before he got ARVs. When he got ARVs, his molluscum started getting better, but his Kaposi sarcoma just got worse. It really just shot off. About 10 to 15% of cases will iris. The way to avoid this is, of course, to give the chemotherapy, which this person certainly needed, alongside the ARVs. If you're giving ARVs, and that often happens especially in the state sector, where there may be delays getting chemotherapy depending on which system you're in and how closely you can access it. And so it's easy to start ARVs, and you should start ARVs, but occasionally that backfires, and you end up with an iris because you haven't treated the Kaposi sarcoma treatment at the same time. This is what it looks like in histopathology. The key thing to look for is these spindle cells, rather. These are kind of transformed cells. They're actually of lymphatic origin, lymphatic endothelium, almost certainly, but they get transformed by Kaposi sarcoma, and then they form these slit-like channels where red cells can get in. The red cells, those channels don't have basement membrane, so the red cells actually just kind of extravasate out just as easily as they get in and cause quite a bit of problems. So the name is actually terrible when you think about it, because it's not a sarcoma. It doesn't derive from mesenchymal tissue at all. It's actually an endothelial tumor, but obviously it wasn't known when Moritz Cohn or Maurice Kaposi decided to call it a sarcoma. So this is roughly what it looks like, and this is what you're looking. Of course, it would stain HHV-8 positive as well on immunohistochemistry, which is virtually diagnostic in this case, in conjunction with these features. And then they, like I said, they contain these slits containing red blood cells. Also, some form of angiogenesis as well is very common in these histopathological specimens. We know how to treat it. You do need to give ARVs. Remember, some of them can iris, but you shouldn't hold off ARVs, and because the 10 to 15% of them iris, but the other 85% of them get better, at least tries to contain them. Getting immune reconstitution seems almost required to get on top of Kaposi sarcoma. And in mild cases, of course, maybe enough on its own. If you have to go to specific therapy, obviously, and you guys will know more about this than me, limited disease, you may get away with, if it's very limited, just ARVs alone. Otherwise, intralesional chemotherapy, radiation therapy, and obviously if it's you may need systemic chemotherapy if there's either non-responsive to those local measures, or if it's very extensive, like the pictures I've shown you, or if there's visceral disease, obviously you need chemotherapy, and some form of liposomal anthracycline is usually what's given internationally. Most of this, but it's again sad in a way, because really getting people on ARVs would avoid most of this. Interestingly, it doesn't seem to be any role for antivirals, and despite it being driven really by HHV-8, you don't get Kaposi sarcoma without it. It doesn't appear to help, at least in Kaposi sarcoma, to give antivirals. We know that certain of our antivirals will work. Ganciclovir will work, for example, and Foscarnet and Cidofovir. They'll all inhibit HHV-8 replication. But interestingly, most of the cells here are in the latent stage, not the lytic. So remember, the latent stage is not actively replicating. And so these antivirals really don't have much effect. That may not be true in some of the other conditions it causes, but it does seem to be true in Kaposi sarcoma, which is a pity, again, because it would be a good way to treat it otherwise. I'm not going to cover most of the lymphoproliferative components because Roman is going to cover it next. Just wanted to skim through them, obviously, just to show you the extent of them. But the primary fusion lymphoma, obviously, there's two forms, but in the classic form, without any solid component. This is the B cells, remember. So the first Kaposi sarcoma is the endothelial part, where HHV-8 infects that. Here is HHV-8 infecting the B cells, and in this case, causing a primary fusion lymphoma. It's pretty uncommon for us. About 3% of HIV-associated lymphomas, but you can get it without HIV, but it's uncommon. Fortunately, it's not that difficult to diagnose, because if you get wherever the fluid is, like the pleural space or the acidic fluid or something, it's almost always positive, and of course you can stain it for HHV-8. We don't know the optimal treatment because we don't have prospective trials, but many people will give CHOP or EPOC. Again, I'm going to skim over this and hand that to Romana, who's more qualified for that. In prognosis, though, is really dismal here, and untreated maybe 2 to 3 months, even with treatment with ARVs and chemotherapy, often under 6 months. And that's really sad in a way, because this is not a type of cancer that people bounce back from occasionally. You do get exceptions, but most of them do pretty poorly. One interesting thing just for clinicians to be aware of potentially is what's called this peacock sign. This is an abdominal CT, obviously, and what you've got here is these radially arranged, so in a sort of circle like that, distended bowel loops around the mesenteric vessels associated with the ascites. So ascites being the sort of halo, if you like, and then it looks a bit like peacocks. So here's the mesenteric vessels coming out, and you've got those rings of bowel loops arranged in a sort of on the radius of that circle. You can kind of see why they call it the peacock sign, and that's meant to be usefully diagnostic of primary fusion lymphoma, especially in an HIV-infected patient. It's not totally pathognomonic. There's occasional other things that can do it, but that's something to look out for when you're otherwise stuck, because it's easy when you know the diagnosis, but remember, most of these patients in the clinical sphere are going to be treated for so or at least suspected of having TB or something like that. So you need something else to shift you towards primary fusion lymphoma. HHV-8 associated multicentric carcinoid disease, again, I'm going to just skim through this because, again, it's going to be covered next. It's, again, this lymphoproliferative disorder, fever and lymphadenopathy being very common, splenomegaly and hepatomegaly in most cases, and pulmonary infiltrates, interestingly, in about a third. And that's quite interesting as well, not something I would have necessarily thought. Again, if you happen to get histopathology, that's really how you diagnose it, and the typical features associated with HHV-8. In this case, you obviously get multicentric carcinomas that's not HHV-8 associated, but in this case it is. One just point for the clinicians, again, is to remember that about 40% of them, when they're HIV positive, have associated Kaposi sarcoma, and it's often in the same lymph node even. So if you biopsy these lymph nodes, you may see multicentric carcinomas and Kaposi sarcoma. That's not hugely uncommon to see, but it's pretty dramatic when you do, again, driven by HHV-8. And again, treatment I'm going to really skim over, but it depends on whether you are HIV positive, whether there's coexisting Kaposi sarcoma, and whether there's life-threatening organ failure, and the decisions you'd make from that. And then I wanted to show you one case we had recently of that. So he's a 40-year-old male. His CD4 was 110, and it's interesting, it's not strongly associated with low CD4, this multicentric carcinoid disease, unlike some of the other features of HHV-8 associated malignancies. He had fever, abdominal swelling, loss of weight, loss of appetite, night sweats, cough. Interestingly, remember I said about a third of them have pulmonary involvement. Here was some of his CT scans. You can see a big spleen over here. He had some hilar lymph nodes. These are inguinal lymph nodes on either side here. So lymph nodes really everywhere. When they were biopsied, you can see quite nicely here, this staining in this sort of dark brown is the HHV-8 on immunohistochemistry in typically this mantle zone around the follicle. And this sort of plasma cell variant or plasmablastic variant over here on the edge here. So again, diagnosis by histology, and if it's associated with HHV-8, that should also stain up. And then I wanted to just finish with this one last syndrome, because I think this is one of the more interesting things, and it's not at all well appreciated by clinicians. It's probably quite rare, but I think we miss bucket loads of it. So it's got this horrible name, Kaposi sarcoma associated herpes virus. That's the other name for HHV-8. So think of it as HHV-8 inflammatory cytokine syndrome. So that gives you kicks. If you did HHV-8, so it would give you hicks, which would be even worse. But that's the syndrome to remember. It's basically multicentric carcinoid disease, but without evidence of multicentric carcinoid disease on histology. So in other words, the syndrome fits, but the histopathology doesn't. It's certainly driven by HHV-8, but it appears to be this hyperproduction of cytokines which drive most of this. And I'll show you in the next slide some other things. So this is one example. The reference for this paper is in the next slide. But you get this fever, fatigue, edema, cachexia, respiratory syndromes, gastrointestinal, anemia, thrombocytopenia. These people are incredibly sick. Lymphadenopathy, very common, splenomegaly, hepatomegaly, evidence of increased inflammation, but when you biopsy them, they don't show evidence of multicentric carcinoid disease on histopathology. But what it's always associated with is this very high HHV-8 viral load. So more than 1,000 copies, but usually much, much higher, up to the millions often. And also, interestingly, if you measure that viral interleukin-6, remember I mentioned that all the way back. If you measure the viral interleukin-6, it's sky high as well, like 10 times the upper limit of normal, 100 times, 1,000 times the upper limit of normal. So it seems to be really in HIV positive people who get this, and then they have HHV-8, and that HHV-8, because of the HIV, the lack of control of the HHV-8, gets this sort of uncontrolled replication, and it starts infecting all of these B cells and these endothelial cells, but you don't get the full Carcinoid's histopathology. However, you get the cytokine release everywhere. The mortality is up to 60%. It's really, really high, and no one knows how to treat it because, of course, so rarely been described. It took into the 90s for this first to be described, and only a few case series since then, but I bet we miss a lot of them. So it's the time to think of it would be someone who, say, has Kaposi sarcoma, because many of these people also have Kaposi sarcoma, but who has these prominent systemic features and multi-organ dysfunction that's not associated just with the Kaposi sarcoma being present in those tissues. It's not like it's spread to the lungs or the gastrointestinal tract. It's really cytokine driven. But it's, if not recognized, it can have an enormously high mortality. And even when it is recognized, sometimes you don't win. But the way to do it is to measure the HHV-8 viral load, which is easier said than done. It's not available by the NHLS, for example. And then to, if you can, even measure that viral interleukin-6. Human interleukin-6 is also sky high, so if you can measure that, In these cases, at least it's indicative. Very, very difficult though, and difficult to know. So that's me. I'm going to hand over to Romana, but I just wanted to show you again the spectrum and why this is so tricky. So this is this KICS syndrome, which I just mentioned. Of course, you can have multicentric Castleman's disease and a KS iris. So how would you tell these apart? These are nightmares for clinicians. Effectively, remember that the Castleman's disease will have that histopathology that will help you, whereas the KICS will not have the histopathology, but you will have the high human and viral interleukin 6, and also this high, low CD4, high HHV, but also the high HHV-8 viremia. In Kaposi, whereas in an iris, of course, you must see that iris reaction. The CD4 must have come up a lot. The viral load must have come down a lot in a fairly short period of time. And that's when you might get to it. So there's a lot here, and I'm pretty sure we missed this, because I think these three conditions on the page here, KICS, the multicentric Castleman's that's associated with HHV-8, and KS iris, are very difficult to tell apart. But if you don't remember this, if you at least remember there is such a thing as this, you can at least look it up when you get these syndromes and think about what this might be. So that's where I'm going to leave it. I want to just remind you that HHV-8, like all cool viruses, is really nice to know about. It's got a very high seroprevalence in sub-Saharan Africa, which is probably why we see so much of these conditions, much more than the rest of the world, because of course we have a lot of HIV, and you marry that with a lot of HHV-8. Whereas if you look at other parts in the world where there's a lot of HIV, there often isn't a lot of HHV-8. Here we have both. And we know that probably these lymphoproliferative disorders are collateral damage from the virus's own attempts to survive by evading the immune system and to replicate. It's not trying to cause cancers. That's probably just a disorder because the host is weaker than average, and some of its immune avoidance strategies get out of control. But just remember as well that we're probably missing a lot of them. We miss a lot of primary disease, but who cares? Doesn't matter. But we probably miss a bunch of KICS because we found a few since we started looking at our hospital, and they are disasters unless you find them early. So I think hopefully that's some food for thought. And thank you very much. I'm going to hand over to Romana next.
Thank you very much, Jeremy. That was a very interesting talk. I hope you can stay till the end of the meeting so that we can actually have questions, take all the questions together. Next up is Dr. Romana Jasset, who, thanks, Jeremy, who is the fellow at Chris Hani Baragwanath Hospital. She is a fellow in clinical hematology and is in her second year of training currently. She qualified as a specialist physician from Baragwanath Hospital. And you've heard Romana speak last year, so I think she's very familiar to all of you. Thank you, Romana. If you can go ahead with your talk.
Hey, good afternoon. Thank you for the introduction, Dr. Philip, and thank you for the opportunity to present on this forum. It's always difficult to follow an eloquent speaker like Dr. Nell, but we'll try our best. Today, I'm going to be discussing HHV-8 associated lymphoproliferative disorders. And given the limited time period for this talk, I will largely focus on primary effusion lymphoma. There has been a separate deep dive on multicentric Castleman's disease. And so for the purposes of this talk, my focus will be mainly on primary effusion lymphoma. This will be the outline of my presentation. I will start off by discussing two very interesting cases. The first case being patient 1, which I've entitled a triple threat, just to highlight the considerable overlap between all of the HHV-8 associated lymphoproliferative disorders. And next, I'll discuss patient 2, a case of primary effusion lymphoma, but where's the effusion? Next, I'll discuss a broad overview of the HHV-8 associated lymphoproliferative disorders, and then I'll finally hone in on PEL, discussing the pathogenesis, clinical elements, and diagnostics. Very importantly, in my opinion, the most important element is the differentials and how did we arrive at these particular diagnoses? What is the management of primary effusion lymphoma? And is there really any standard of care for the diagnosis and the management? And lastly, and importantly, what is our local Baragwanath experience with regard to primary effusion lymphoma? So I'll start off with patient 1, Mr. JM, a triple threat. So this is a case of Mr. JM, a 42-year-old patient with a poor ECOG baseline score of 3. He was retroviral disease positive with a CD4 count under 100 of 97. And he actually presented to the local clinic with symptoms of generalized lymphadenopathy, predominantly involving the left supraclavicular region, but he had adenopathy in the cervical, axillary, and inguinal region as well. Unfortunately, this patient was inappropriately managed and he was started on empiric TB treatment without a proper workup. The gene expert, however, was subsequently found to be negative, but he was already on TB treatment for about a month at the time. He then subsequently presented to Baragwanath Hospital with, not surprisingly, progressive symptomatology. His nodes were increasing in size, he had shortness of breath, cough, and significant constitutional symptoms. In addition, he had skin lesions that were present on his bilateral lower limbs that resembled chronic plaques. So just to mention his examination findings, he had generalized lymphadenopathy, bilateral cervical involving the anterior and posterior cervical chain, bilateral supraclavicular masses, and bilateral axillary masses. In terms of his chest examination findings, he had significant decreased A entry on the left side, indicative of a massive pleural effusion, but a negative to S-spine signs, so no features of adenopathy or features of SVC obstruction. In terms of his abdominal examination, he had significant ascites, but no genomegaly. The dermatological examination showed these violaceous plaques, which were present on the lower limb, very suggestive of Kaposi sarcoma. However, he had no oral lesions that were present. Just in terms of the staging CT that was done, as expected, an extensive nodal disease or extensive nodal burden with multiple lymphadenopathy present throughout the chest. In terms of his liver and spleen, he had liver hypodensities and splenic nodules and significant ascites. In terms of his effusion, he had this massive left effusion with a mass effect in the midline shift, as well as multiple pleural nodules. The bone marrow aspirate and trephine that was performed, however, showed no infiltrate. So not surprisingly, given his clinical presentation, clinical features together with the staging CT, the consideration at the time was, could this all be disseminated Kaposi sarcoma with multiple visceral organ involvement? Fortunately, however, a lymph node biopsy was performed and it showed a dual pathology present in a single node. And I think Dr. Nell alluded to this earlier. Initially, the first pathology was these prominent follicles with the concentric layering of peripheral lymphocytes, which resemble an onion skin. And for those of you who know, that is a classic description of Castleman's disease. Given the fact that the patient had multiple clinical sites of adenopathy, this favored multicentric Castleman's as opposed to unicentric Castleman's. And in addition, apart from the follicles with the concentric layering, there was a diffuse infiltrate of plasma cells between the follicle. So this combination of features favored the mixed hyaline vascular and plasma cell variant of multicentric Castleman's. But that's not all. In addition, in this node, there was also evidence of Kaposi sarcoma, indicative by a vasoformative spindle cell proliferation with, as mentioned, the red blood cell extravasation and hemosiderin pigment. Quite a classic description as well. Just to confirm, the immunohistochemistry that was done was HHV-8, which was positive in the spindle cells with the classic dot-like or punctate nucleus staining, which we've come to know. The plasma cell marker CD38 was also positive, and as we expect with multicentric Castleman's disease, the EBA in situ hybridization was negative. So this is some of the morphology, and this is the Kaposi sarcoma element. These beautiful images are courtesy of Dr. Peta from the NHLS, and we thank her for these images. But just to appreciate the spindle-like type of proliferation with the intravascular hemorrhage in between. For those of you that are maybe not accustomed to looking at anatomical pathology specimens, perhaps the drawing would be more appropriate, where you appreciate the spindleized endothelial type of lesion together with the blood-filled spaces with an associated plasmacytosis. In the same node, this is the morphology for the multicentric Castleman's disease. And as you will appreciate, the follicles in the center surrounded by this concentric ring of lymphocytes, giving the typical onion skin type of appearance. Sometimes there is a feeding type of vessel, and it may give a lollipop type of appearance. This is the immunohistochemical stain that was done, and as you will appreciate, the diffuse positive HHV-8 diffuse positivity. And when I just zoomed in on the particular picture, you can appreciate the punctate nuclear staining, which is quite typical. So side by side in the same node, the concentric multicentric Castleman's disease together with the spindleized endothelial cells. So we have a dual diagnosis present in a single node. However, that's not all, folks. Still other investigations that were performed in the same patient was an examination of his pleural fluid. So on a pleural tap, it was found that he had a significant exudative pleural effusion with a markedly elevated LDH and ADA. Gene expert on the fluid that was performed was not surprisingly negative, and the cytology that was performed on the fluid showed these large atypical lymphoid cells with the classic apoptotic background, which is what is described in the case of primary effusion lymphoma. And cytologically, the pleural effusion fluid was compatible with a large cell non-Hodgkin lymphoma. However, just to confirm, flow cytometry was performed on the pleural fluid, and quite typically it demonstrated the following: the larger cells, which were more complex on examination, which expressed CD45, although it should be noted that sometimes CD45 or LCA is not expressed, and this may create some confusion and may lead you down a different path. The plasma cell markers CD38 and 138 were positive, and then your B cell markers CD19, CD20 were not expressed, which is also what we come to expect in primary effusion lymphoma, and there was no expression of your light chains. So the findings on this pleural fluid was of that of a terminally differentiated B cell or early type of plasma cells, and given the site or the location of the disease, the considerations at the time were either a primary effusion lymphoma or a plasmablastic lymphoma. B-cell immunoglobulin gene rearrangement studies was also performed, and this demonstrated clonality on the pleural fluid. So just to summarize, we have a patient that has got a triple threat of 3 diseases occurring in the same patient. Number 1 being HHV-associated multicentric Castleman's.
Sorry, could you all mute your screen, your mics, please? Thank you.
Okay. Okay, so just to summarize, we've got a patient that has got 3 diseases which coexist. Number 1 being HHV-8 associated multicentric Castleman's, just taking note of the fact that you can get an idiopathic type of Castleman's disease, which is not associated with HHV-8. It was of the mixed hyaline, vascular, and plasma cell variant. Next, we had Kaposi sarcoma coexisting in the same node. And lastly, primary effusion lymphoma. So I just created the summary from this particular case for myself and for all of the other trainees as well, just to highlight what did we have to confirm the diagnosis in every case. So in terms of the KS, clinically, the patient was immunocompromised. He had this generalized lymphadenopathy, lower limb plaques, splenic and liver nodules, as well as pulmonary nodules. Diagnostically, the morphology was typical with the spindle cells with associated hemorrhage and plasmacytosis. And it was finally confirmed immunohistochemically with the HHV staining that was positive. In terms of the multicentric Castleman's, the patient was immunocompromised. He had this generalized lymphadenopathy, which favored multicentric over unicentric, significant constitutional features, which is a hallmark of multicentric Castleman's, and biochemically raised inflammatory markers as well as hypoalbuminemia. Diagnostically on morphology, we had these abnormal follicles with the typical onion skin lymphocytes surrounding them, together with the interfollicular plasma cell hyperplasia. And based on immunohistochemistry staining, the HHV-8 was positive, plasma cell markers were positive, and the eBay issue was negative, and that is what we come to see in multicentric Castleman's disease. In terms of a primary effusion lymphoma, the patient had features of an effusion, both in the pleural cavity as well as ascites. The fluid demonstrated these large lymphoid cells with an apoptotic type of debris. And in terms of the immunohistochemistry, the cells expressed dermis CD45, a lack of P and B cell markers, a demonstration of your terminally differentiated plasma cell markers, and clonality was demonstrated with IgH on the fluid. However, HHV-8 was not performed on the fluid, although I'm told that you can cytospin the sample and perform HHV-8 staining on the pleural fluid. So in terms of the management of this case, just to take into account that this case was from 2015 and our regimens have subsequently changed in the coming years, but the patient was promptly started on ARVs together with supportive management, which included multiple therapeutic taps, and combination chemotherapy was started. And the regimen that we opted for at the time was a CHOP regimen, the standard CHOP with the addition of etoposide, probably for the benefit of the multicentric Castleman's disease, with the addition of bleomycin to assist with the Kaposi sarcoma element. Also of note, there was no rituximab was added, probably as a risk of flaring the Kaposi sarcoma. Unfortunately for this patient, the outcome was rather poor, and after one cycle of chemotherapy, the patient subsequently demised. So that was case 1. I just want to move on to patient 2, which has got a difficult type of clinical presentation before I move on to the discussion. And case 2 is of patient Mr. SS. And this patient is a 40-year-old male patient who had a better ECOG baseline score of 1. He was also RBD positive with a higher CD4 count of 150, and this patient was on ARVs since 2019. He was admitted from Johannesburg prison. And this patient actually was presented to the respiratory unit with massive hemoptysis, and hematology was subsequently consulted. He presented with a history of progressively enlarging lymphadenopathy with significant loss of weight, but no prior history of TB or any type of opportunistic infections to explain his presentation. Clinically on examination, he had generalized lymphadenopathy involving the bilateral cervical, anterior and posterior cervical chain, as well as axillary and inguinal nodes. On his chest examination, there was dullness over the left base, although it was not stony dull, and a loud P2. The CT neck and chest that was performed showed extensive bulky cervical adenopathy, as well as a filling defect in your left pulmonary artery with an associated wedge-shaped consolidation suggestive of a pulmonary infarct. However, it was also noted that he had a right upper lobe pleural-based mass, but no associated effusions. The bone marrow aspirate and trephine that was performed showed no infiltrate. So these are some of the pictures used with the patient's permission. As you will appreciate, the bulky adenopathy, and as you will appreciate on the CT scan, a large pleural-based type of mass, but no associated pleural effusions. So other investigations that were performed, there was a lymphadenopathy excision biopsy that was performed, which again showed an infiltrate composing of large cells. Some of them had a typical plasmacytoid type of appearance. And based on the immunohistochemistry, which helped us with the diagnosis, the CD45 or LCA was negative in this case, which could have thrown you a little off. The patient had aberrant expression of the T cell markers. The B cell markers, CD20 and PAX5, were negative, but your plasma cell markers, 138, MUM1, and 38 were positive. Again, to confirm the diagnosis, HHV-8 was positive with a diffuse nuclear punctate staining in the tumor cells. Also, the Ki67 index, which is a marker of proliferation in our malignant patients, was approaching almost 100%, so around 95%. So this was the morphology of this particular case taken from the excisional biopsy. And as you will appreciate on this particular slide, the marked pleomorphic nature of the cells. So these cells, some of them may appear plasmablastic, some may have more of an eccentric type of nuclei and appear plasmacytoid, some may look larger and anaplastic in morphology. And also to illustrate that aside from these large type of cells, you also can appreciate these background, debris or apoptotic tingible bodies in the background, indicative of a very high proliferative type of tumor. The CD138 that was done again showed diffuse positivity. And the HHV-8 staining, or the LANA, the latency-associated nuclear antigen stain, showed the punctate staining in the nuclear region. And the Ki67, again, indicative of a highly proliferative type of tumor, approaching around 95%. So the differential diagnosis at the time for this particular case was, could this be, given the fact that the disease was in the nodes, could this be an HHV-8 associated or HHV-8 positive diffuse large B cell, or could this be an extracavitary primary effusion lymphoma? Something to help differentiate these two entities was the EBA, which was positive in the tumor cells. And given the fact that the EBA was positive, this, together with the disease presentation, rather favored an extracavitary primary effusion lymphoma. And the patient was subsequently treated with 1 cycle of CHOP, and he remains well to date, and we are currently following him up. So I'd like to start off my discussion by firstly focusing on an overview of the HHV-8 associated lymphoproliferative disorders. So this is a very nice diagram which I've adapted to a certain extent, taken from blood, and it just illustrates. So firstly, the HHV-8 is also known as Kaposi sarcoma herpes virus. You will appreciate the Kaposi sarcoma in the center, and then the association with all the other lymphoproliferative disorders. The main one that I always mention is primary effusion lymphoma, together with extracavitary primary effusion lymphoma, HHV-8 associated diffuse large B cell not otherwise specified, HHV-8 associated multicentric Castleman's disease, and lastly at the bottom, the geminotrophic lymphoproliferative disorder. Just to highlight that all of them are associated with HHV-8, whereas we generally see EBA in situ hybridization positivity with the primary effusion lymphoma and with the geminotrophic lymphoproliferative disorder. Also, to just illustrate that they are generally all associated with immunocompromised states in various forms, whether retroviral disease, post-transplant, etc., except for the GLPD at the bottom, which is normally in immunocompetent individuals. As mentioned by Dr. Nell, there's also an element of KICS, which is your inflammatory cytokine syndrome, although it's I included it here, although it's not really part of the lymphoproliferative type of disorders per se. So just to illustrate the differences, and many of you will appreciate this table from the WHO, the differences between multicentric Castleman's, diffuse large B cell, and the geminotrophic lymphoproliferative disorder. I didn't include primary effusion lymphoma because I'll go into that a bit more later, but generally just to highlight from this table that they may present in a similar way. All patients will present with lymphadenopathy or splenomegaly and constitutional symptoms, and therefore to discriminate between, to differentiate between these three entities can be quite challenging. Morphology is quite essential for multicentric Castleman's, which shows abnormal follicles together with your interfollicular plasma cell hyperplasia, compared to a diffuse large B cell where you may see sheets of plasmablastic cells, compared to a GLPD where you may see retention of the nodal architecture. Just to illustrate that HHV-8 positivity is positive throughout, whereas EBA, as mentioned, is negative in Castleman's and diffuse large B cell not otherwise specified, however, it is positive in GLPD. In terms of retroviral disease, as mentioned, generally the first two conditions are associated with immunocompromised states as compared to GLPD, where patients are immunocompetent. So let's move on to primary effusion lymphoma, or PEL, in more detail. So this is the terminology which is taken from the new WHO 5th edition, and it basically defines primary effusion lymphoma as a B cell neoplasm, generally a large cell, the keyword is large, presenting generally as serous effusions. When they talk about serous effusions, they generally mean pleural, pericardial, peritoneal, and it normally involves a single cavity, although in our case, we have noted multiple cavities being involved at the same time. They mentioned that it's normally without any detectable tumor mass, although they may be associated body cavity related tumor masses, as in our second case where we had a pleural-based mass, but it's not an extranodal type of mass. They are normally HHV-8 positive by Lana immunohistochemistry. Patients are generally immunocompromised from any sort of retroviral disease, post-transplant, or even in the elderly just from immunosenescence. It's typified by these large pleomorphic cells with a terminally differentiated B cell immunophenotype, i.e. the CD38, 138 is positive, but your typical CD19, 20, 79A will all be negative. There are numerous risk factors for the development of primary effusion lymphoma, among them being the immunocompromised states, post-transplant, age, as well as MSM. It's important to differentiate primary effusion lymphoma from the subtype of extracavitary primary effusion lymphoma, which is a related entity, but in this case, the patients present with a tumor mass, which can be nodal or extranodal, and extranodal generally being the GI tract the most commonest. However, there has been cases documented in the CNS. There's no associated diffusion, and they generally have similar morphology and immunohistochemistry stain. It's important to note that it's normally co-infection with EBV is common in about 80% of cases, but this really supports the diagnosis and especially in the context of retroviral disease where you may have co-infection with EBV, but it's not necessary to make the diagnosis. The old terminology was body cavity-based lymphoma, which is not used anymore. And you should basically differentiate these two entities from a PEL-like lymphoma, which is associated with a fluid overload state, but it's HHV-8 negative, and it's generally seen more in the elderly, less likely to be associated with retroviral disease. In terms of the pathogenesis, I won't go too much into this. Dr. Nell alluded to this, was that HHV infects the whole cell in two different forms, number one being latent infection and number two being lytic infection, latent infection being the default position. And there's a numerous number of gene products that are produced which have got a role in lymphogenesis. The most important one is the LANA1, which is what we use for immunohistochemistry, as well as its pathogenic mechanism by binding tumor suppressor genes. Other things to mention are your V-flip, your coposin B, and your V-cyclin.
Hello.
So just in terms of the diagnostic criteria for primary effusion lymphoma, generally they presented as mentioned with lymphomatous type of infusions, really directly related tumor mass, no extracellular involvement generally. And the important thing to highlight is that the patients have associated conditions like Kaposi sarcoma and multicenter Castleman's. So if you've got one, generally look for the others. Extracavitary PEL presents with solid tumors at an extranodal site. It can involve the GIT, skin, CNS, bone marrow, or even intravascular type of sites. Diagnosis is generally made on cytological preparations by cytospin of the effusion fluid, whereas extracavitary PEL is made by biopsy of the tumor mass. Morphology I mentioned are these large cells which have got a plasmablastic, immunoblastic, or anaplastic morphology, quite a pleomorphic type of appearance with a background of apoptotic debris, and sometimes they may be multinucleated and resemble the Reed-Sternberg cell. Immunophenotype, just to recap, may lack CD45 and therefore send you down a non-hematolymphoid path. They lack B cell markers. They have markers of plasma cell markers. They can have aberrant T cell markers, and generally your HHV-8 is positive and your EBA-ish is positive as well. If you do IgH gene rearrangement studies, clonality will be demonstrated. In terms of the prognosis, generally both have a poor prognosis. Some of the poor or some of the factors associated with the poor prognosis is the poor performance status. If the patient did not receive any prior retroviral disease therapy, and if generally there's more than one associated cavity, all are basically associated with poorer prognosis. These are just some of the images taken from the ASH image bank, just to illustrate again the pleomorphic nature of the cells, as well as the LANA positivity. And again, these four images illustrating the cells on H&E, the HHV positivity, and then the EBA positivity as well, quite diffuse positivity. I'd like to just move on to the differentials now, and how do we come to a diagnosis of primary effusion lymphoma, which is really a rare type of diagnosis to make. And I think this was a very nice picture, which was taken from a practical lymph node and bone marrow pathology textbook. And it really helps to narrow the diagnosis based on morphology. So if you see under a microscope plasmablasts or immunoblasts, I think the first step would be to do your B cell markers or your panel of CD20, CD19, PAX5. If it's positive, you are then generally going down the route of diffuse large B cell lymphoma, perhaps the immunoblastic variant. And if it's negative and you see the terminally differentiated B cell markers or your plasma cell markers that are positive 138, 38, then you will proceed further down. If those markers are positive, then I would say you do your ALK, your Epstein-Barr, and your HHV-8. If those markers are negative, though, then you are going down your anaplastic large cell or perhaps a non-hematopoietic if your CD45 is negative. But if you do your ALK, your EBV, and your HHV-8, and your ALK is positive, you are going down the route of anaplastic large cell, your B cell subtype. If your HHV-8 is positive, then you're considering multicenter Castleman's, diffuse large B cell, GLPD, or primary effusion lymphoma, the latter two being EBV positive. If your EBV in situ hybridization is positive, but your HHV-8 is negative, then you consider plasmablastic lymphoma, and I think that's key. In our case, there was a consideration of plasmablastic lymphoma, but the HHV-8 was positive. Although also taking into account that there is an entity of EBV negative plasmablastic lymphoma. So if EBV is negative and HHV-8 is negative, then your differential should be either plasmablastic lymphoma or plasmablastic type of myeloma. Just again to illustrate the differences between plasmablastic lymphoma and primary fusion lymphoma, which can create some confusion. They may obviously have a different type of presentation, but the morphology, immunophenotype, and EBV positivity is generally all the same. So what will help to differentiate between the two will be co-infection with HHV-8. In terms of the management principles for primary fusion lymphoma, just to illustrate that there is no standard of care because there's no randomized controlled trials and the reports of management of primary fusion lymphoma is largely based on anecdotal evidence in small case series. The main principles to note are: number one, you should address the patient's comorbidities, including their retroviral disease. What is their performance status and risk stratify them? If it's a younger type of patient, you would consider intensive chemotherapy. If it's an older patient who's quite frail with numerous comorbidities, perhaps a more palliative type of approach would be more appropriate. It's important to mention that ART or ARVs are the backbone of treatment, but the interaction between your ARVs and your chemotherapy should be considered, particularly with the regimen that we will choose. Cyclophosphamide and vincristine both work on the cyclone P450 system, and therefore there's a considerable ART interaction, and therefore in this case, the integrase inhibitors are preferred. Also, it's important to mention that the prognosis is generally poor because of a lack of CD20 expression in these particular tumors. And we know that rituximab has really revolutionized the treatment of B-cell lymphoma, and we really don't use rituximab for primary fusion lymphoma. Also, there's a concern if with concomitant KS with using rituximab regarding a KS flare. It's important to remember that despite your best efforts, the prognosis is generally poor, and the future management is really directed towards immunological recovery, overcoming the immune escape, overcoming all of these mechanisms that this virus really has, and lastly, targeted molecules, which seem to be the way of the future. So the commonest regimens that has been studied in smaller studies has been either dose-adjusted EPOCH and the CHOP regimen. And in the largest spell series by Bollinger et al., he described the following: either a CHOP-based regimen, which is what we use in our center. Number two, an intensified CHOP regimen, in other words, with the addition of methotrexate, high-dose methotrexate. Although the issues with methotrexate is the penetration of methotrexate into the effusion, what should be the method of administration, and how about the delayed clearance and increased toxicity in the effusion fluid. There's also been reports of a CHOP-like regimen, which I found very interesting, where you avoid the prednisone, the P in the CHOP stands for prednisone. You avoid the prednisone because of a risk of the KS flare. In other regimens that have been studied are the ACVPP. In terms of high-dose chemotherapy followed by autologous stem cell transplant, not really being studied, although they did mention that they consider it in a younger patient in the case of a relapse refractory primary fusion lymphoma. And lastly, molecular targeted therapies targeting the numerous NF-kappa beta, JAK-STAT pathway. All of these pathways seem to be the way of the future. So this is just a diagram from Blood, and the article was entitled The Biology and Management of PEL, just to illustrate that there are numerous molecules or numerous targets of therapy that are being studied in terms of the novel agents. The one that I found, or a couple that I found interesting, was bortezomib from myeloma fame, which has got proteasomal activity and may help. And proteasomal activity is required for the survival of PEL cells. So by inhibiting the NF-kappa beta pathway, bortezomib may have a role. Brentuximab vedotin, which is what we use in relapsed refractory Hodgkin, given the fact that these tumors may be CD30 positive. And lastly, daratumumab, because of the expression of CD38. And therefore, daratumumab being an anti-CD38 monoclonal antibody may also have a role. What about antiviral agents? Well, there is a theoretical target of HHV-infected PEL cells, but as mentioned, that HHV exists predominantly in the latent stage, and therefore there is a new concept of viral induction therapy where they try and get the virus from the latent phase to the lytic type of phase, where these drugs seem to work, but the effectiveness is largely in primary fusion lymphoma based on case reports, and also the route of administration has not been studied. Do you give these agents into the cavity, into the pleural cavity, etc.? What is the best way of administration of these antiviral agents? What should you do in the case of a combination? So combination disease, patient with KS together with rituximab. It's important to mention it's up to 70% of patients with multicentral carcinomas have KS. And if patients have multicentral carcinomas, they're at a 15-fold risk of developing non-Hodgkin lymphoma. So this is a nice diagram from UpToDate just to illustrate that if you've got concomitant HHV-8 with Kaposi sarcoma and the patient is low risk, you can consider just weekly rituximab. If there's life-threatening organ involvement, on the other hand, you consider weekly rituximab together with either liposomal doxo or etoposide. And also to mention in UpToDate, they say that they give antiviral agents or ganciclovir if concurrent KS because of the risk of the exacerbation with rituximab. So what is our local experience in Beira with regard to PEL and extracavitary PEL? Well, there was only about 10 cases that were documented, and this was done from 2005 to 2023. There was about 10 cases. The majority, 70% of the cases was predominantly primary fusion, and 3 cases that we found was extracavitary primary fusion lymphoma. As expected and as documented in the literature, the male to female ratio is 2.3:1, the mean age being about 40. There was no cases in anyone under 20 and no cases actually in anyone over 60 either. The majority of the patients were retroviral disease positive and the majority were not on treatment. There was one case with concomitant PEL and KS and the case that I mentioned with PEL, KS, and multicentral carcinomas. Although I must mention, we see a lot more KS and multicentral carcinomas alone without the PEL element. So just to say, where did we find or what type of effusions? 2 were pleural, 1 was pericardial, and the patient actually presented with pericardial tamponade. 1 was ascites alone, and 2 cases were multiple cavities, so both pleural and ascitic. In terms of extracavitary PEL, 2 patients had the disease that was diagnosed in lymphadenopathy, and 1 actually, quite interestingly, was in a leptomeningeal mass diagnosed on biopsy. Unfortunately, as expected, the outcome was quite poor. 60% of patients demised. There's only 1 that is currently alive, and about 3 that have been lost to follow up. In terms of the regimen choice that we chose, CHOP for 3 of our cases, CHOOP with the addition of etoposide for 4 of the cases, and unfortunately 3 patients did not receive any treatment and demised before any treatment could be initiated. So just the final conclusions on this topic was that the spectrum of HHV-associated lymphoproliferative disorders is quite vast, and they have got numerous overlapping type of concepts. There's a significant overlap. If you see one condition, for example, KS, always try and look for the others. There's a subtype, which I didn't know before starting this talk, of primary fusion lymphoma and extracavitary primary fusion lymphoma. There's no standard management guidelines for the upfront or the relapse refractory setting, and targeted therapeutic agents seem to be the way of the future. Thank you.
Thank you very much, Romana, and thank you to both of you for the excellent presentations. I've actually learned quite a bit from your talks. I think there are many questions. Can I start with Dr. Malab's questions? I wonder how rare HHV-8 Castleman's really is. We see a lot, don't have exact numbers, though. Romana, do you know how many we get? I know we get quite a large number, though.
I don't know the exact numbers, Dr. Philip. I think, if I'm not mistaken, Prof has done a study in the past, a book chapter, I think, on multicentral carcinomas at Beira, but I don't have the numbers offhand.
Yeah, I know he has, and I can't remember either, but we can check that. It seems that Kicks and Castleman's may just be similar diseases on the same spectrum. I agree with you, Jacques, and I think the problem here is that they're probably being missed, and biopsy may be done and nobody's thinking about it, or the patient comes in very sick. I'm not sure about, I think the rest of the country is very similar to Baragwanath, where our patients first get TB treatment for months before they're referred through I think we might be missing the diagnosis in a lot of these patients. Treatment seems very much similar. What is the clinical significance of the differentiation? Would either one of you like to answer that question?
Ramona, I mean, I don't know if you want to. So I definitely don't want to talk too much about treatment because that's outside my wheelhouse. But I will say I think that if it's just between multicentric Cosmans and KICs, no, there probably isn't much difference in terms of treatment. But I think the big thing is the recognition, because it expands that thing. So, for example, if you've got a patient with KS who's now got lymph nodes, hepatosplenomegaly, and systemic features, and you're worried about Cosmans, you biopsy, you don't see Cosmans, you know, it sounds to me like it's helpful to know that that's actually a patient you may want to add rituximab. You know, if you really do think that this is a KIC syndrome associated with it. It's hard though, because we don't have access to HHV-8 viremias, at least not as far as I'm aware. I mean, perhaps you have by research labs and other avenues, and certainly not the viral interleukin-6s and things like that. It's just, it seems hard to diagnose. And then, of course, if you are worried about multicentric Cosmans and you don't find Cosmans on histopathology, it seems good to know that you may still want to treat it as such, you know, on the assumption it could be this KIC syndrome. So I think it's mostly just recognition. I agree that if you only have those two things on the table, then it doesn't really matter in terms of treatment. I think it's hard, though, outside that, when there's so many other considerations too. I don't know if that makes sense, or if others want to add anything, because like I said, I'm feeling a bit outside my comfort zone with discussing treatment.
My worry is that they're not even being referred to the hematologist because the biopsy is not showing Castleman, so general physician is actually not picking up that it's potentially KICs and doesn't refer them through to us for treatment. And that's probably where we are missing them. Because I don't think I have seen a case of KICs. I genuinely haven't seen a case of KICs being referred to us. And then Jacques, yes, he gives us the answer to his own question. Rituximab plus etoposide, I agree with you. That's generally what we tend to do. We haven't added valganciclovir to any of our patients. It would be very interesting to see, but we have very limited access to it, so difficult for us. And Jacques says we can do a qualitative HHV-8 PCR. Would that be adequate, Jeremy?
Look, it's better than nothing, because at least you're in the ballpark. But I mean, the problem is, it's the level which is useful, because you may get even a low level viremia in just simple KS, for example. But I mean, look, it's better than nothing. I mean, negative would be useful. I see Jacques got his hand up as well. I don't know if there's other parts you want to add in.
Jacques, please go ahead.
Yeah, I just wanted to make that comment that, I mean, we can determine if it's negative or positive, and that may help in some cases where you have a potential relapse and you're not certain. So if you've got a multicentric Castleman's disease and you follow them up and they've got recurrence of symptoms, it's the question, is the Castleman's relapse, or have they now transformed into a true lymphoma? So I mean, we do the qualitative HHV-8 PCR periodically, and it does help with follow-up. And just a note on the valganciclovir, we've had a couple of patients offhand. I can think about 2 or 3 that had relapses after their primary treatment with rituximab, and they seem to do well when you retreat them, and then we generally put them on the valganciclovir to prevent further relapse. And I mean, very anecdotally, they seem to do quite well. So I think another message for the trainees is that to always consider lymphoma sort of transformation into a true lymphoma when you have a sort of a relapse situation.
Yeah, thanks, Jacques. I must say, we actually need to think about it. Relapses we retreat, and we've had actually reasonably good outcomes even with retreatment and have gotten them back into remission for longer periods as well. But it is a good consideration. Are there any other questions? Oh, we are on time. We have time for more questions if anybody does want to ask. If not, I'd like to thank both the speakers for excellent talks. And Jeremy, if I was a bit younger, I might have considered infectious diseases, but unfortunately not this late in my life. Thank you both. They were really wonderful talks and appreciate them. And thanks for both your inputs.
Thanks.
Thank you. Apparently there's no talk next week because it's a holiday, so we'll see you in 2 weeks' time. Thank you, everybody, and goodbye.